He serves as the president of the Turkish Society of Reproductive Medicine and is a clinical researcher specializing in female infertility, endometriosis, and assisted reproduction. Additionally, it sits on the editorial boards of leading journals in the field and has received numerous awards for research, education, and quality of patients' care from prestigious institutions such as McGill University, the American Society of Reproductive Medicine, and the Koç University of Istanbul. Professor Ata, please, the floor is yours. I just recommend respecting the scheduled time for your lecture, which is 12 minutes, okay?
12 minutes, okay, I'll try to be.
Okay, please, go ahead.
All right, so good morning. So 12 minutes, Attilio, Sergio, thank you for the invitation. It's a wonderful meeting, dear colleagues. So no conflicts of interest in this sense, but I have other, say, disclosures, if you see it that way. So I think I'm assigned to the kingdom of ART, but I'm connected to the kingdom of ultrasound as well. I do all my ultrasounds myself, congenital anomalies, 3D, automated, non-automated. I used to publish in the field. We even do endoscopic ultrasound. And I may be also, connected to, sorry, the other videos don't play, but anyways, the kingdom of hysteroscopy. I do operative hysteroscopy, diagnostic hysteroscopy. And if there were a kingdom of reproductive surgery, this I really feel close to it too. We're just publishing a paper on the relevance of reproductive surgery and why it should be done by reproductive surgeons who all know reproductive physiology, who know ART, who know all the other options. Anyways, so time is short. I have a problem if I don't understand the logic behind the concept. I mean, it doesn't stick with me. I can't function with it. It was the same in medical school. It was the same in the high school. That's why I didn't really graduate with very high grades. Okay? So that's me questioning everything. When I started practicing, actually learning ART 19 years ago, recurrent implantation failure was one of those concepts that I didn't understand the logic behind it. Right? So I didn't even understand the definition. Is it 2 embryos? Is it 5 embryos? Is it transfers? Is it embryos? Is it cleavage? Is it blastocyst? Is it fresh? Is it frozen? Is there an age? Right? And today, more or less, the situation is the same. So what was the logic behind it? The logic behind it is, if you think of it as a functional term, it should have a meaning. It should direct you in the clinic in the sense, like you should be expecting that this patient should have become pregnant by now unless there's something obscure that I don't know, I couldn't diagnose, I couldn't treat. Right? So it's not meeting the expectation, right? But then, what is our expectation? Did we ever expect every embryo to implant? No. We wouldn't question that. So even in fertile couples, even at the peak of human fertility, like early 20s, monthly fecundity is hardly 25%. So as species, we are terribly inefficient in producing competent oocytes and sperm, and only a percentage of those oocytes sperm pairs have the potential to reach to live birth, and that increases dramatically with age. So what is the effect of age, actually, and what is the reason, the most common reason behind implantation failure? If you regard implantation failure as the hoofbeat in the saying, then the horse is aneuploid. Right? So meiotic failure, mostly, unfortunately, in the oocyte. So in this slide, there are like 80,000 embryos from different publications. Okay? And what they invariably show, aneuploidy, is limitedly detected by the currently available technologies, increases with age, and even under the age of 35, close to half of the blastocysts, the embryos that make it to that stage, that make it to biopsyable quality, are still aneuploid. They don't have the potential to reach live birth to start with. So this is, undoubtedly, unequivocally, the most common reason. So where does this bring us? Is there any rationale could it be logical to have a definition of recurrent implantation failure without taking this and age into account? You see two identical embryos. Actually, it is two photos of the same embryo. Right? So what is the chances of that embryo reaching live birth? It depends on the age of the patient. Okay? So as an example, if the patient is 29, the chances that it will be euploid is 60%. If the euploid embryos implant in the absence of other pathology, like 65% of the time, because euploidy is not everything. We don't check for every single gene. We don't check for every factor in the embryo. The overall chances of dead blastocyst from a 29-year-old woman without testing for chromosomal abnormality would be 39%. If the same looking embryo belongs to a 42-year-old woman, its chances of being euploid is 25% roughly. Even if it implants at the same rate, the chances of reaching live birth is less than half of the younger person's embryo. So we cannot put them in the same basket. We cannot have a definition without adjusting for age. So we did a model with Dado here. So if you were transferring untested blastocysts in different age groups, and if you set a limit to call, recurrent implantation failure, otherwise unexplained, say, I would expect this patient would be pregnant by 95% chance now if the only problem was aneuploidy. Even in the younger patients, you would need like 5, 6 blastocysts, not 2, not 3. Right? And today, it would take multiple cycles. In the older patients, it is almost practically impossible to reach that threshold. Right? So we are absolutely overdiagnosing unexplained recurrent implantation failure. It's mostly explained by aneuploidy to start with. Okay? And if you do a similar modeling with euploid blastocysts, they are reported to implant at different rates, in the literature. In any case, you reach this 90% threshold by 3 euploid blastocysts, which is consistent with real-life data, as Paul showed yesterday. You rule out known, obvious causes of implantation failure, factors that would affect the chance of implantation. When you isolate aneuploidy, okay, so 92% of people will deliver with 3 euploid transfers. So now I think this is the most important part of the talk to explain the concept of enrichment, which is in the Lugano paper again. So at the top, assume you have 1,000 patients and 100 of them have an unknown pathology, unknown endometrial uterine systemic pathology that we are not able to diagnose, that makes it impossible for them to have implantation, to have live birth, right? And the remaining 900 have the usual implantation rate. For the sake of the sample, let's say it's 70%. You do the first transfer, overall chance of implantation would be 63%. Then the remaining 370 women undergo a second transfer. Now the 100 women with the impossible pathology is more than 1/3 of the population. Even if embryos implant at 70%, the observed implantation rate in the whole population now decreases to 51. And if you do a third transfer, you see the 100 women now comprise more than half of the population. They comprise more than half of the denominator for the third transfer, and your observed implantation decreases to 31. If you would do a fourth, that would decrease to 13%, 14% from 61, even if your embryos implant at the same rate for women without that secret pathology. Okay? So that is the concept of enrichment, and the studies that have been shown yesterday was testing if this enrichment happened. Okay? So here is real-life data. If you look at SART data, the blue line shows if there were 5% of patients with such pathology, that is how implantation rate would look in consecutive transfers on the x-axis, if it was 2%, if it was 1% with the gray line. The red line shows the real-life data in SART registry, so it's not decreasing at that rate. So if it exists at all, it should be less than 2%. And then we did this study Filippo showed yesterday. It's been shown in other talks, I think. 124,000 almost patients. We screened 124,000 people who was ruled out for other obvious pathology, who underwent 3 euploid transfers without any positive pregnancy test in the same institutions, and we could only find 105 women who were resilient enough, who didn't change the center and underwent a 4th, and if it failed, underwent a 5th. The question was there a perceivable decrease in the 4th and in the 5th transfer? So is enrichment happening? If you look at the data at the bottom, live birth rates are 40%, 53%. It's consistent. So enrichment doesn't seem to happen even at a rate of 1%. That is what the study shows. That doesn't mean people will necessarily deliver 98%. So what this shows is when we expand the New Jersey data with the 4th and 5th transfers from New Jersey in the sample, yes, once you rule the known pathology, the obvious pathology out or treat it, and if the patient is persistent, you continue with euploid transfers, yeah, this is real life data, 98% of them eventually deliver. So what happens with other problems? Let's say if the patient has adenomyosis, if the patient has hydrosalpinges untreated, if the patient has intracavitary pathology, what would happen probably? The chances per transfer would be lower at a certain rate, but whatever it is, it will probably remain the same with consecutive transfers. So that patient's cumulative chance of live birth may be less, okay? But the point we are trying to make is it would be persistent, consistent between consecutive transfer cycles probably, unless it's a progressive condition. And just by extending the graph with our 5 transfers, you see where the data reaches, in an unknown pathology, if it exists at all, which it may, if something can go wrong, it invariably goes wrong in some people, but it's happening in less than 1% of the population. So we're not the only people, we're not the only teams who are saying this. This is a paper published in Human Reproduction earlier. So, every transfer is not the same transfer. It's not the same embryo. We are changing an important, probably the most important variable with every transfer. We're transferring a different embryo. The way I explain this concept to my patients is I ask them, are you conceived spontaneously? Yes. Do you have a sibling? Yes. Is your sibling the same as you? No, but your parents conceived your sibling the same way, so you do the same thing, but you get a different embryo, you get a different genetics, you get different everything. So it's not repeating the same thing and expecting a different result. Actually, it is changing the most important variable. So the data-driven conclusions, unexplained recurrent implantation failure is probably extremely rare. Recurrent implantation failure is an abstract concept, which I doubt if it helps anybody, okay? We are supposed to diagnose and treat known pathology before the first cycle or whenever it appears. If you have any doubt, when you do a karyotype with current technology, you almost cover all the bases, and recurrent implantation failure, such a concept may become relevant in a few limited scenarios, right? So the numbers, the facts always stick, and they always prove over time, as witnessed by Bruno's statue. Last 2 slides. So the moral of the story, the purpose of the lecture, is not uterus doesn't matter. Obviously the uterus matters. Obviously the endometrium matters. It's not euploidy is the only factor. Right? So it's not. There are other factors relating to the embryo, relating to the patient. Right? It's not you have to do PGTA, but you just need to consider aneuploidy, the probability of aneuploidy when you're making clinical inferences. It's not you should ignore everything else and just keep transferring even if the patient has a fundal polyp, even if the patient has an intracavitary fibroid, even if the patient has adhesions. No, it's not the point. And the point is absolutely not everybody has to undergo 5 transfers. Most of them will get pregnant and a live birth before. So the moral of the story is we should diagnose and treat known pathology that affects implantation before the first treatment cycle or whenever it appears in the course of patient's treatment. Since euploid blastocysts seem to implant at a persistent rate across different transfers, so there's no enrichment, there's probably, if there's an unknown pathology, it is extremely rare, and the moral of the story is, rather than demoralizing the patient, labeling her with a vague diagnosis of, oh, you have unexplained recurrent implantation failure, which has huge negative connotations, we should just try to keep them in the treatment loop. I think that's the best service. And the moral of the story is, except for proper research, we should not spend people's time and money in unproven stuff, and save those for a next treatment cycle if they're undergoing ART anyways. And most patients will deliver way before the 5th transfer. So we are supposed to be doing it right at the first time. And I like this quote: a winner is just a loser who tried one more time. Thank you. I don't know if I can make it in 12 minutes. But